What's up, everybody? It's Miles here from bootcamp.com, and today in pulmonology, we're going to be going over airflow and airway resistance. So one basic concept to understand is that as air flows from a large airway into a small airway, the resistance to airflow is going to increase because it's harder to push air through a smaller airway. When we talk about small versus large, what we're referring to is the diameter of the airway. So for a small diameter airway, the resistance is going to be large compared to a large diameter airway. And this applies when we're talking about individual small airways compared to individual large airways. So the individual small airway resistance is larger than an individual large airway resistance. However, when we're considering total airway resistance, there are way more small airways than large airways. So if we draw in a bunch of small airways here, the result is that our total cross-sectional area of all of the small airways combined is much larger than the total cross-sectional area of the large airways combined. So in total, the actual total resistance of the small airways is smaller than the total resistance of the large airways. And so we have that over here. The total small airway resistance is going to be smaller than the total large airway resistance. And where the resistance is the highest is actually in the medium-sized bronchi, and that's because not only is there not very many of them, but their diameter is also smaller than the large diameter airways. So a classic graph would look like this. On the x-axis, we would have the progression of the respiratory system going from the trachea all the way down to the small airways, and on the y-axis we would have resistance, and so resistance is going to be very high in the large airways, and it would peak in the medium-sized bronchi, and then it would decrease as we get down to the small airways. Alright, and now let's go over lung volume and how it relates to airway resistance. So one of the concepts here is that we have all of these airways going through the lungs, but between the airways, we have something called lung parenchyma that is attached to the airways. So if we take a look at these two diagrams over here, the airways are represented by this airway in the middle, and these lines radiating out from the airway represents the lung parenchyma that is tethered to the airway. And because the parenchyma is tethered to the airways, as the lungs expand, like in this diagram over here, that lung parenchyma that's tethered to the airways are going to pull open the airways and stretch them out. So as the lungs expand, that parenchyma is going to be pulling outwards on the airways and stretching them out, and that's going to increase and enlarge the diameter of the airways. And so when the lungs expand, the airways are also going to expand, and as the airway diameter increases, the resistance is going to decrease. Likewise, as the lungs collapse, the airways will also collapse, and so the diameter of the airways are going to decrease, and that's going to increase the resistance. Alright, so with all that in mind, now we can start to compare the properties of obstructive lung conditions to restrictive lung conditions. So let's start off by discussing the obstructive lung disease basics. And so as the name implies, somewhere in the respiratory system, there is going to be an obstruction to airflow, and as a result, there is going to be increased resistance to airflow in the respiratory system. And one of the main obstructive lung conditions that you want to keep in mind is something called COPD, which is chronic obstructive pulmonary disease. It has elements of both emphysema, which we've already talked about, and another condition called chronic bronchitis. And one of the main reasons why COPD has an obstruction to airflow is because the equal pressure point is close to the alveoli. And so you might need to go back to the video on equal pressure point for this one, but recall that emphysema is characterized by a destruction of elastic tissue, and so during inspiration, we're not going to have very much elastic recoil, and as a result, we're not going to be pulling on that pleural space very much, and so we're not really going to generate that negative of a pleural pressure. And so our pleural pressure will never get to negative, and as a result, the transpulmonary pressure is going to decrease, and this is going to lead to a small alveolar pressure at the start of a forced expiration. And as a result of that, our alveolar pressure gradient from the alveoli to the mouth is going to be very small. This is going to lead to the equal pressure point being close to the alveoli in a region that is not protected by cartilage. And furthermore, the area just above the equal pressure point, which is also in a region not protected by cartilage, and where the pleural pressure exceeds that of the airway pressure, we are going to see collapse. In the case of chronic bronchitis, which we'll be discussing more in future videos, in this condition we have a lot of mucus plugs. And so we'll just draw in some mucus plugs in the airway on this diagram to the left here. And these mucus plugs themselves are an obstruction to airflow. However, as air moves through these mucus plugs, the pressure on the other side of the mucus plug is going to drop off very quickly. So in the case of chronic bronchitis, the alveolar pressure might be normal at the start of expiration. However, once the air moves through the mucus plug, the pressure is going to drop off very quickly, such that the equal pressure point is also going to be moving closer to the alveoli. And because it's close to the alveoli, it's in a region that's not protected by cartilage, and so we are also going to see collapse like in the case of emphysema. So in both emphysema and in chronic bronchitis, we're going to see collapsed airways. One thing to keep straight that is sometimes confusing is that high compliance lung conditions such as COPD and emphysema are usually obstructive lung conditions. However, not all obstructive lung conditions have lungs that have high compliance. So just remember that high compliance just means it's easy to expand the lungs, whereas an obstructive lung condition means there's an obstruction to airflow. So in the case of emphysema, it's very easy to expand the lungs, and as a result, we go through all of this equal pressure point physiology that we just discussed, and we see that the pleural pressure flattens the airways, and that's the obstruction to airflow. Whereas when we talk about another obstructive lung condition, such as asthma, their airways aren't collapsed as a result of high compliance. In asthma, the compliance of the lungs are completely normal. The reason that they have obstruction to airflow is a problem intrinsically with the bronchioles. We have constriction of the bronchioles due to inflammation, and so the airways in an asthmatic patient are going to look something like this. They are constricted and inflamed and full of mucus, and that's the reason why there's an obstruction to airflow. So just try to keep that straight. High compliance usually results in an obstructive lung condition. However, not all obstructive lung conditions have high compliance lungs. So now I'm going to get into a topic that I've seen come up in boards questions, and it's called the work of breathing. So the way that we discuss the work of breathing is we draw in a graph like this, and on the x-axis, we're going to be plotting respiratory rate, and on the y-axis, we're going to be plotting arbitrary units of work. And so one thing to understand is, let's just bring it back to our video on ventilation for a second. So we said that minute ventilation is equal to our tidal volume multiplied by our respiratory rate. And one thing you always want to keep in the back of your mind, and we'll talk more about this in future videos, is if you want to maintain normal blood gases, so normal oxygen and normal CO2 levels in the blood, and we're not exercising, we're just at rest, in order to maintain these gas levels, we have to have a constant minute ventilation. So this means that if I increase my respiratory rate in order to maintain normal ventilation, I would also need to decrease my tidal volume. And furthermore, if I decrease my respiratory rate to maintain ventilation, I would need to increase my tidal volume. And so with this concept in mind, as we increase our respiratory rate on the x-axis, we're also going to be decreasing our tidal volume. And likewise, when we decrease our respiratory rate on the x-axis, we're also going to be increasing our tidal volume. So just keep in mind that as we move this way on the x-axis, we're increasing our respiratory rate, whereas if we move this way on the x-axis, we're going to be increasing our tidal volume. All right, so before we put our curve in here, let's just apply a few more concepts. So one concept that we learned in this video is that at high lung volumes or at high tidal volumes, when those lungs are expanded and that lung parenchyma is pulling the airways open, our airways are going to be at a higher diameter at high lung volumes, and that's going to decrease airway resistance. And likewise, at low lung volumes, the airways are going to be collapsed, and that's going to result in high airway resistance. And lastly, when the lungs are really stretched out and we're really stretching out those elastic fibers, there's going to be a lot of elastic recoil force and a lot of collapsing pressure. So on the left side of the graph, at very high lung volumes where the lungs are very expanded and stretched out, there's going to be a lot of elastic recoil force and a lot of collapsing pressure. And on the right side of the graph, where the lungs are at a low lung volume and they're not very stretched out, then we're going to have low elastic recoil force and not that much collapsing pressure. So now let's just draw in our normal curve, and the normal curve kind of has a U shape to it, so it kind of looks like this. And the reason it looks like this is because on the left side of the graph here, it takes a lot of work to overcome all that elastic recoil of those stretched out lungs. Whereas on the right side of the graph, it takes a lot of work to overcome the airway resistance of those collapsed airways. And so work is minimized in the middle of the graph here, which corresponds to a respiratory rate of about 15 breaths per minute. So now let's add in our obstructive lung condition curve. And the thing that you need to understand is recall that the main problem in obstructive lung conditions is they have that obstruction to airflow, which is causing increased resistance to airflow in the respiratory system. And so the obstructive lung condition curve is shifted to the left compared to normal because it's trying to get away from those low lung volumes where the airways are collapsed and the air resistance is high. So the obstructive lung condition curve kind of looks like this. So their work is minimized somewhere over here at high tidal volumes and low respiratory rates. And so it's for this reason that COPD patients are going to be breathing at high lung volumes and low respiratory rates, because at high lung volumes, we're decreasing airway resistance because we're opening up those airways. All right, so now let's talk about some restrictive lung disease basics. And as the name implies, the lungs are restricted from opening and expansion is very limited. And 99% of the time, expansion is limited because the lungs have low compliance. However, it is possible to have a restrictive lung condition with normal compliance lungs, like we talked about earlier. Maybe it's restricted from opening because the lungs are trying to expand against a tumor or something. But in about 99% of cases, like I said, you really want to be correlating restrictive lung disease with low compliance lung conditions, such as pulmonary fibrosis and ARDS and NRDS. And there's just a classic radiology picture on the bottom right here, and you can see all of these white markings which represent collagen deposition. And so this is pulmonary fibrosis, and all of that collagen is making it very hard for the lungs to expand. And because it's so hard to expand the lungs, we need to use a lot of musculature, and as a result, we're going to be pulling really hard on the pleural space. And so we're going to be generating a lot of negative pleural pressure. And even though we might not expand the lungs very much, that negative pleural pressure is really going to pull on the lung parenchyma, and that's really going to pull on the airways and cause the airways to expand. And as a result of this airway expansion, in restrictive lung conditions, we usually have low airway resistance. And when we plot our restrictive lung disease curve on the work of breathing graph here, the curve is actually going to be shifted to the right. And that's because the problem isn't airway resistance. The problem in a restrictive lung disease is that the lungs have a hard time expanding as they're trying to overcome a large collapsing pressure. And so they want to stay away from these large tidal volumes where the lungs are very expanded and there's all that additional elastic recoil. And so the restrictive lung disease curve is going to kind of look something like this. So we can see that their work is minimized right here. They're going to be breathing at low tidal volumes because they're trying to minimize the work of all that elastic recoil at high tidal volumes. And so in a restrictive lung disease patient, they're going to be breathing at low lung volumes due to the fact that they already have a large collapsing force, and because they're breathing at low tidal volumes, they need to compensate by breathing at a high respiratory rate to maintain ventilation. And so to summarize, for obstructive lung disease patients, they're going to be taking slow, deep breaths over here because at high lung volumes, the airways are going to be open, and that's going to minimize the work of overcoming airway resistance. And for restrictive lung disease patients, they're going to be breathing over here which is going to be fast and shallow breaths because at low lung volumes, they're going to be minimizing the work of overcoming elastic recoil. All right, and that's all we got for our video on airflow and airway resistance.